Discuss today is importance of audit detection. Before going to the actual topic, let's see what is the incidence of hearing loss in our country. About 3,000 children born have a hearing loss, and about 20% of children born with hearing loss have profound hearing loss. So as you see from the data which is available, there is a high degree of hearing impairment in our country. Hearing loss develops after birth is up to 3% of children. What we are doing, really looking over here, is the window of opportunity. There is a time, it is called a critical period of speech and language development, and in other terms now it is called window of opportunity. What really we have to work is in this limited time frame. If the job is done in a timely manner, then the things would work out well for the child. Diagnostic delay. Average delay of diagnosis in India is very high. The parents are first to identify the hearing impairment, and as a clinician, we must acknowledge their concern and try to do the needful for them. When they say, I think my child has got hearing impairment, we should honor them. Maybe it is true or false, that we have to find out whether it is true or false. But normally what happens, the mother especially, we get so many stories coming up now. Mothers say that I could make out that my child has got problem, because olden times when we started our practice, the things were not there. Now a lot of objective tests have come into the audiological test battery, which makes it easy to identify a hearing loss, as we saw various tests described by Deepa Rami. This is what is a good representation from borrowed the slide. This is absolutely normal functioning system, and this system is like a computer. As a computer crashes, and then when the things are fine, it's all good. But what happens, when the system crashes, there is auditory signal which is going, and the centers in the brain are working in complementary to each other. But when there is a hearing loss, there is a faulty input which is going up to the auditory cortex, and as you noticed over here, that the part which is supposed to be for the auditory purposes of primary auditory cortex, secondary area, and the association areas are all here, are taken by the visual cortex. So there is an encroachment because there is no auditory or effective auditory stimulation going on in the high level. So there is an encroachment. What happens is any senses in the body, either you use it or lose it. This is another representation which explains the neural cell populations, dendroid axons. At birth, you have got very few of them, and as auditory maturation takes place, by the age of 2 years, you see it is densely populated neural system. And again onwards now, as the time is passing by, you see by age of 6 years, again the neuronal population is begin to shrink. So what really we need to do is we have to target this area where there is a maximum neural cells which are available. This is what happens. Parts of the infant's brain are pre-programmed or hardwired. Everybody has got the potential. It is the part which needs to be filled by the sense organ in the plastic. Those are the plastic areas. The areas are all there. It just needs to be filled in with an appropriate information, either auditory, visual, or whatever other senses. Auditory system does not mature without stimulation. You need to have effective stimulation, without which you cannot expect. Deafness leases the synapses in immature state, and auditory stimulation thaws the stimulus system out of its frozen state, and then it resumes normal maturational sequences. So you need to do first proper timely detection, and then a good appropriate intervention. Most important period of language and speech development is generally regarded as first 2 to 3 years of life. This is an old kind of a situation. What is the latest current scenario is, and this is from the study which is, it's called the Colorado study, and what they have found is that children diagnosed before 6 months and who receive appropriate and consistent intervention have significantly better language levels than children identified after 6 months. So now that window has come down to 6 months of age. So we need to be really think promptly in order to get a good outcome. And the most important aspect of treatment of hearing loss in children is early detection of hearing loss. Sensory deprivation, when there is improper or faulty signals which are going through the auditory system, what you get is that will be produced. If you hear faulty signals, if you hear faulty speech, or if you hear the smeared sound which I showed in the morning, or those clues which are missing, you will be going to be producing in the same way. That's what we have got deaf-like speech, because they hear faulty, they talk in the same manner. So when there is improper or inappropriate input, it affects the receptive language skills and an expressive language skill. If you do not have receptive and expressive language which is age appropriate, you are going to have further problems in development, like you have reduced spoken language abilities. As a result of that, you get a lower social academic result, and which affects the social and emotional development of a person. So what we really want to do is to give a social opportunity, educational opportunity, and a good quality life by proper intervention and diagnosis. Reduced auditory input affects developing of auditory nervous system, as we already saw in the previous slide. This is another study which I want to highlight here, is called Hanover experience. And in this, as you see, because what they have done is they have seen the children who are mainstream and age of implantation. And the outcome of the study is the children implanted before the age of 2 years when in mainstream education almost 6 times as often as children with hearing aids. So this is a very nice study, and as you see, they get better opportunity and they can be independent individual with less burden on the society. That is what we should aim at. Early identification, as I said, early identification, there is one goal which we all have to follow, and it's called 136 goal. What it means is infants are screened for hearing loss before hospital discharge or by 1 month of age. And then if you identify, the speakers who are going to follow me are going to be talking about it. And if you identify a hearing loss, if you do a screening test, if you find out a patient gives refer as an outcome of the screening assessment, needs to have a diagnostic assessment by 3 months of age. And then if they are identified as having whatever degree of hearing impairment, need to have proper interventional services by 6 months. Another thing which I really want to highlight over here is we talk more about profound hearing loss and profound hearing loss, because those are going to have a lot of effect on the child and child's development. But we always forget to keep the people who are having mild to moderate or moderately severe, or let's say mild to severe category of hearing loss. This is really very sad thing in our country, as we have hearing impaired children who are not so much hearing impaired, has to be fitted appropriately. But we say, okay, you fit a hearing aid and then say go. It's not enough for them. They are the big sufferers. Profound hearing loss person, you may do intervention, cochlear implantation, and then when you have done cochlear implantation, and actually you are going to do proper intervention because you spend big sum. But that should not be the situation. You have to, all the professionals have to remember, the audiologists, hearing aid clinicians who are fitting hearing aid, to the client, no matter whether it's a child or an adult person, need to emphasize little bit amount of training or guidance or some tips or some help to be given. Just by fitting a hearing aid is not going to solve their problem. So it is found, it is a very sad thing that children with mild hearing loss, which is in children mostly is because of conductive hearing impairment as a result of serious otitis media, fluid in the middle ear cavity, are the biggest sufferers. They lack much more than the profound hearing loss cases if they are managed well. So this is one thing I really want to highlight, and everybody should practice that in their actual practice. So there is 136 goal, and who should be screened for hearing loss? Ideally, it should be universal hearing screening program, and as Mrs. Gore said, that it's in our country, it's a sad thing that it is just in a very primitive state. There are few places where the actual program is on. We really need to have many more such programs to identify early and then subsequent intervention. Infants admitted in NICU have increased risk of sensorineural hearing loss, and that is between 3 to 5%. So even any child is admitted in NICU for whatever other problem, I think it is better to screen them and send them off. Who knows, he may have hearing loss. So this is what really needs to be. Another thing, what happens if they are having a critical problems and medical management involves ototoxic drugs, the noise of the incubators and things like that, and there are other factors, exchange transfusion. There are many factors which can cause hearing loss in this population. They may pick up a infection from the NICU itself. So the cross infection kind of a situation need to be screened and then sent home. This is, I'm going to quickly go through at-risk group, or which is called high-risk register. The first thing, put it A, B, C, D, G, like kind of a situation. A is asphyxia. B, bacterial meningitis, and in cases of meningitis, we have to be identifying a hearing loss, and timely intervention needs to be done. Then comes congenital perinatal infections, torch infection, defects of head and neck, elevated bilirubin levels. If the levels are greater than 20 milligram per 100 ml serum, then it will cause some damage to the auditory pathway. These children most probably will have some kind of auditory maturational problem or ED or dysynchrony kind of a syndrome, and very high frequency hearing loss is a diagnosis. Then the family history. If there is a family history of hearing loss, we need to be checking them, and if there is a low birth weight, we need to find out whether there is any associated secondary problem with the child. And there are other things, persistent pulmonary hypertension, severe neonatal sepsis, and parental consanguinity. As we saw, the consanguineous hearing losses are there. There's a high, big chance of getting a hearing loss in a consanguineous marriage. So that really needs to be done. And infants with low ACA score of 0.3 needs to be screened. And finding consistent with a syndrome associated here with hearing loss, as Dr. Tejal explained, needs to be identified. All this, will miss approximately 50 to 70% of congenital hearing losses. So the best solution is universal hearing screening program. It starts with screening, and screening basically has two tests. One is OE, and it is AABR, which is automated ABR. It is very quick procedure, non-invasive, and it does not take more time, and it's not very expensive also. This is, I don't know whether Mrs. Gore is going to take this up. So if she's including this, then I'll skip the slide. So the parents and children need your support, knowledge, and ongoing information Let's help the deaf child in the race against time. Thank you very much. Refer. You don't say fail, it says refer. So when you have a person who is passing both the tests, then the family is you just go and look at the family history or any other high risk factors which I have discussed. And if there is high risk, then you need to monitor this child on a regular basis. If there is no high risk of family history, no further follow-up is needed. Only you need to tell the parents to keep watch, and if they suspect hearing loss, they should seek your help. And here now, if the person does not pass your screening test, then you need to repeat the screening after 3 months and just see what result you obtain. If you have again somehow the child missed this thing and has developed this kind of a result, you again go back and look whether there is family history and follow the same route. But if the person passes, he does not pass at this time again. He was referred and reassessed, and again it comes referred here. Then you need to subject the child to diagnostic ABR, OE, other objective tests, SSCP or impedance testing, and you also always have to be correlating your result with behavioral observation audiometry. There was a thing which was going on regarding auditory neuropathy in that panel discussion. So what really happens is there is a variable degree of hearing loss in auditory neuropathy cases. So they are good for a cochlear implantation, but provided they have got profound hearing loss and get limited benefit with hearing aid, and they are surely not going to get benefit with hearing aid or adequate benefit with hearing aid, the cochlear implant, the auditory neuropathy cases, and there is a high incidence of those patients getting good benefit with cochlear implant. So maybe if they have profound hearing loss, maybe the criterion is changing. It's going to severe to profound hearing loss are getting cochlear implant if the diagnosis auditory neuropathy. And so you will really need to be very careful in managing there. So we have to have all the tests. There is no shortcut. Objective tests are there. They are very good tests, but you cannot just do objective tests and send the patient back home saying, okay, things are fine. You need to be correlating with behavioral testing. And this, we had a case. I am sure many more of you have also experienced. There was a child who was 8-9 years who was referred to us at ABR represented the maximum level, robust OEs were present, and an ED ASM because the child had other problems also because of the insult which has taken place in a very bad phase earlier in the life. So he was not really very cooperative, and he couldn't understand as a result of dysynchrony kind of a situation. ASSR also gave very vague kind of a thing. So if you would have just left it like that, it would not have been a proper management. And audiogram and all those results were really not matching with each other. So you need to be doing, and what we have decided is we have gone and taken behavioral responses as a main thing, and we are doing management on those lines. We have disregarded all the objective testing or so-called automatic tests. Okay, so you have to have a diagnostic testing to differentially diagnose the hearing loss, whether it's a sensory hearing loss or it's a conductive hearing impairment. And if you find there's a conductive hearing loss, then the management is medical or surgical intervention is needed. And if there's a sensorineural type of hearing loss, then the child gets into the early intervention program for further management.
Thank you for your wonderful presentation.